Imagine taking a muscle in your body and, well, stretching it to over 3 times its normal length.
Right, which sounds completely impossible.
Exactly. I mean, if you tried to stretch your hamstring or, your bicep, even a fraction of that amount, the muscle would completely snap.
Oh, yeah. It would be a catastrophic orthopedic emergency.
But during childbirth, the human pelvic floor does exactly this. The structures down there stretch to an absolutely staggering degree just to allow a baby to pass through. And today we're looking at what happens when those structures, when they do not bounce back.
Yeah.
Welcome to the Deep Dive. We have a highly specific mission today for you, drawn from a custom-curated stack of medical research, clinical studies, and regulatory guidelines. We are answering one core question. Can birth trauma affect orgasm intensity through vaginal laxity?
And the clinical data we're pulling from to answer that, which includes the DevelopBest study, insights from pelvic floor physiotherapists, and official guidance from both the FDA and the UK's National Institute for Health and Care Excellence, or NICE. All of that reveals a physiological landscape that is just rarely discussed in mainstream medicine. I mean, we tend to focus entirely on the visible aspects of postpartum recovery.
Oh, absolutely. Like, society completely celebrates getting back into pre-pregnancy genes,
Yeah, we're doing those abdominal workouts. But we completely ignore the hidden internal mechanics, specifically the muscular and neurological network of the pelvic floor, which really governs so much of a woman's core stability and, well, sexual function.
Right. So to understand how something as complex as orgasm intensity might change, we really have to start with the mechanics of the trauma itself. Going back to that muscle stretch I mentioned at the top of the show, the sources specify that during a vaginal delivery, a muscle called the pubococcygeus.
Which is part of the levator and Mies muscle group, right?
Yeah, exactly. That muscle stretches up to 3.26 times its normal resting length. That's just the biological requirement to allow the baby's head to pass through the pelvic opening, which is anatomically known as the levator hiatus.
And, I mean, the elasticity required for that 3.26 multiplier is a marvel of human biomechanics. It's incredible.
It really is.
But biological tissue has ultimate failure points.
Yeah.
In roughly 10 to 30% of women undergoing a vaginal delivery. And actually, that figure jumps to 45% when forceps are used.
Wait, 45%?
Yeah, almost half. In those cases, the pubococcygeus muscle is stretched way beyond its structural limit. It doesn't just overstretch or sustain a minor tear. The sheer force literally rips the muscle off its anchor point on the pubic bone.
Oh, wow.
Yeah, and in the medical literature, this specific injury is called a levator aneavulsion.
Okay, let's unpack the physics of that for the listener because it's intense. Imagine if half of the deltoid muscle in your shoulder was just, severed from your collarbone.
Right.
You would lose the basic mechanical leverage required to even lift your arm. Like, the muscle belly might still be there, but because it's no longer firmly attached across the joint, it just cannot generate any meaningful force. And that is the exact anatomical crisis happening in the pelvis with an avulsion.
If we connect this to the bigger picture, that mechanical deficit fundamentally alters the architecture of the pelvic floor. I mean, once the pubococcygeus is pulled off the bone, it can't just magically reattach itself.
Right, it's just floating there.
Basically, the muscle tissue physically shrinks and retracts toward the back passage. So because that supportive sling is now broken on one or both sides, the levator hiatus, that central opening, it becomes permanently wider.
Wow.
And the data shows that the avulsed muscle loses approximately 1/3 of its overall contractile strength.
That's huge.
And it becomes about 25% stretchier. So you're left with a pelvic basin that has lost a massive degree of its structural integrity. And that creates the physical foundation for the sensation women often describe as vaginal laxity.
Right, so a torn, detached muscle presents this massive engineering problem for the body. So I guess the logical next step is figuring out how doctors diagnose that altered architecture.
Right.
And how it translates into the day-to-day sensations a woman actually feels. Reading through the medical literature in our stack, there is this massive collision between what patients report and what doctors are trained to measure.
Oh, for sure.
The terminology alone causes significant friction in the clinic, specifically the difference between laxity and prolapse.
Well, that distinction is really where the majority of medical confusion and, honestly, patient frustration stems from. Vaginal laxity is defined as a subjective sensory experience.
Okay.
It's the physical sensation of looseness or a perceived reduction in internal friction, or maybe just a feeling of diminished support during physical intimacy.
Right.
Whereas pelvic organ prolapse, or POP, is a purely structural anatomical event.
Yeah.
Prolapse occurs when the connective tissues and fascia give way, and that allows pelvic organs like the bladder, the uterus, or the rectum to physically descend and bulge outward into the vaginal canal.
Okay, so prolapse is a structural collapse that a doctor can visually confirm and literally measure with a ruler during a physical exam. But laxity is a sensory deficit that only the patient experiences.
Exactly, which means the patient can experience profound laxity without any measurable prolapse at all, just as a patient can have a visually obvious prolapse without feeling any loss of friction or sensation during intercourse.
And the disconnect between those two things was brilliantly highlighted in our sources by the DevelopS study.
Yes, that's a fascinating study.
Yeah, the researchers took a cohort of women who were actively reporting the sensation of vaginal laxity. And they gave them a standardized survey called the Vaginal Laxity Questionnaire, just to quantify what the women were feeling.
Right.
Then they brought those exact same women in for a highly rigid, standardized physical exam using the pelvic organ prolapse quantification system. So they're measuring their anatomy down to the millimeter.
And what do they find?
Here's where it gets really interesting. The results showed absolutely zero correlation between how loose a woman felt on the questionnaire and her physical exam results on the table. Zero.
Wow.
If doctors can't physically measure the laxity on a standard prolapse scale, does that mean the sensation isn't real? I mean, it's like trying to measure the temperature of a room using a tape measure. You're applying a spatial tool to a sensory problem.
This raises an important question, right? Because the total lack of correlation in the developed study proved to the medical community that our standard diagnostic tools are just wildly inadequate for assessing female sexual function.
Clearly.
Because a doctor cannot map laxity on a prolapse chart. Women have historically been told the sensation is just in their heads.
Which is so frustrating.
It is, but the DevelopS data forces the medical field to acknowledge that laxity is a functional and sensory reality. It relies on how tissues, nerves, and muscles respond dynamically under load and friction, rather than just where the organs statically rest when a patient is lying back on an exam table.
Okay, so if laxity is fundamentally tied to dynamic friction and altered sensory feedback, we really have to look at the ultimate dynamic event in this context, right? The mechanics of an orgasm.
Let's do it.
The sources break down the anatomy of a climax, and it is this fascinating, highly coordinated neurological event. It starts with the clitoris, which boasts over 8,000 nerve endings.
Right.
But those endings don't operate in isolation. They connect to a massive network of 15,000 other nerves running throughout the pelvis, heavily involving the pudendal nerve.
Yeah, and when that vast neural network is stimulated up to the threshold of climax, it triggers a powerful reflex arc.
Okay.
The central nervous system sends this involuntary signal straight to the pelvic floor muscles, primarily targeting the pubocauseous muscle we discussed earlier.
Right, the one that gets stretched.
Exactly. And the muscle begins to contract rhythmically and involuntarily at intervals of roughly 0.8 seconds. That pulsing, tight, gripping contraction, that actually is the physical manifestation of the orgasm.
Which brings us right back to the birth trauma. Because if a woman has suffered a levator avulsion, meaning that pubococcygeus muscle has literally been sheared off the pubic bone during delivery, the tension in that muscle is just gone.
Yes.
So to understand how that affects climax, think of it like a guitar string. You can still pluck the string, right? That represents clitoral stimulation. The signal is definitely sent.
Right.
But if the tuning peg has slipped and the string is just hanging loose, which represents the detached PC muscle, you are not going to get that intense, reverberating vibration. The tension required to create the power simply isn't there. So what does this all mean for the listener? Does a torn muscle mean a woman can no longer have an orgasm?
No, not at all. The neurological pathways for arousal, desire, and pleasure, they remain completely intact. The levator avulsion does not damage the clitoris itself.
Okay, that's good news.
Yeah, women with this specific birth trauma can absolutely still reach climax through clitoral stimulation. The loss occurs entirely in the mechanical output. Because the PC muscle is partially detached and severely weakened, the actual physical intensity of those internal rhythmic contractions is heavily compromised. So the gripping sensation of the orgasm itself, it becomes diminished or muted.
Wow. The cause and effect there is just remarkably clear. A torn muscle strips the tension from the system, resulting in a physical loss of intensity.
Right.
But while reviewing the clinical guidelines, I noticed a massive curveball. Physical trauma and torn muscles are not the only culprits behind the feeling of a loose vagina. Countless women experience identical symptoms of diminished friction and reduced orgasm intensity without having any muscular tears at all.
Yeah, we see profound cases of hormonal mimicry that end up confusing both patients and practitioners.
Yep.
A sensation of severe laxity is frequently caused by a catastrophic drop in systemic estrogen.
Oh, okay.
We see this acutely in the postpartum period,
Mm.
especially when a woman is exclusively breastfeeding because prolactin actually suppresses estrogen production. And we see it again later in life during the transition into menopause. Estrogen is essentially the master architect of pelvic tissue health.
So what exactly is estrogen doing on a cellular level that makes its absence so devastating to the tissue?
Well, estrogen receptors are densely packed throughout the vaginal mucosa. When estrogen is present, it maintains the thickness of the vaginal wall, it stimulates the production of natural lubrication, and it drives the cross-linking of collagen and elastin fibers.
Which gives it the elasticity.
Exactly. That gives the tissue its bouncy, elastic quality. Furthermore, estrogen feeds the local lactobacilli, which are the healthy bacteria that maintain an acidic, infection-resistant environment.
Okay, so it's doing a lot.
It's doing everything. When estrogen levels plummet, that entire ecosystem just collapses. The vaginal lining undergoes a process called atrophy. It becomes paper-thin, incredibly fragile, and loses its elasticity entirely.
The physical therapists on our sources note that without estrogen, the tissue becomes completely devoid of moisture. It's like Sahara Desert dry. It loses its rugged, folded texture, the rugae, which naturally provide friction.
Right.
So it's like a sponge that is completely dried out. It feels smaller, less bouncy, and less responsive. A woman might experience physical intimacy, feel an absolute lack of friction, and logically assume her muscles have been permanently stretched out or torn from giving birth,
Yeah.
when in reality, her muscles might be in perfect condition. Her mucosal tissue is just severely thinned and dehydrated from an estrogen crash.
What's fascinating here is the conflation of those two root causes.
Yeah.
Muscular revulsion versus estrogen deprivation. And that conflation is where the medical landscape becomes actively dangerous for patients.
Because they're treating the wrong thing.
Exactly. You have women who are completely convinced their pelvic floor structural integrity is ruined. They feel this intense loss of sensation, and they begin seeking extreme interventions to tighten the canal, completely unaware that their issue is hormonal, not structural.
And with women experiencing symptoms so severe they feel their anatomical structure is failing them, it is no wonder they're seeking out drastic solutions, which completely explains the explosion of the vaginal rejuvenation laser market over the past decade.
Oh, absolutely.
The clinic websites and our stack market devices like the V-Lays or the Mona Lisa Touch as quick, non-surgical miracle fixes that will supposedly completely restore sexual gratification, tighten the tissue, and just fix laxity.
Navigating that treatment landscape requires serious clinical scrutiny, honestly, because the marketing heavily outpaces the validated science. The laser clinics operate on the biological principle of controlled thermal injury.
Wait, thermal injury? How exactly does burning the inside of the vaginal canal supposedly resolve laxity?
So the lasers emit focused energy to create microscopic thermal wounds deep within the vaginal wall. The clinical theory is that this heat trauma triggers the body's natural wound healing cascade. The localized burn creates edema, or swelling, and forces fibroblasts to rush to the site to produce fresh collagen and increase blood flow. Theoretically, this newly generated collagen firms up the vaginal walls and reduces the sensation of laxity.
Well, the clinic brochures aggressively promote an 84% improvement rate using this thermal method. But as you dig into the clinical trials and regulatory documents provided in the stack, the whole narrative just collapses.
It really does.
Let's look at the landmark sham-controlled study. Researchers took two groups of women suffering from these exact symptoms. One group received the actual thermal laser treatment. The other group received a sham procedure, basically a fake laser session to account for the placebo effect, alongside a standard, inexpensive prescription for topical estrogen cream.
And the results of that sham-controlled trial are a critical data point for any patient who is considering these devices.
Definitely.
The women who underwent the actual laser treatments reported a satisfaction and improvement rate of 71.9%. In a vacuum, a 71% success rate seems incredibly promising.
Yeah, until you reveal the data from the control group.
Exactly. The control group, the women who received the fake laser and simply applied the standard estrogen cream, they reported an improvement rate of 82.8%.
Wow.
So the highly marketed, multi-thousand-dollar laser treatments actually underperformed compared to basic topical hormone restoration.
So a patient is potentially paying out of pocket for a thermal injury that is statistically less effective than a simple hormone cream. But the ineffectiveness is only half the story.
Right.
The clinic websites claim an 84% improvement rate with these lasers, but then we have the official NICE guidelines and the FDA basically flashing warning lights. How do we reconcile these two entirely different narratives?
This circles right back to the biological mechanisms of wound healing we discussed earlier, and why applying a burn to estrogen-deprived tissue is so incredibly hazardous.
Okay, lay it out for us.
If the vaginal tissue is already thinned out, fragile, and lacking the estrogen required to organize healthy elastic collagen, hitting that tissue with a laser does not magically create healthy tissue.
Right.
Instead of forming pliable collagen, the thermal injury heals rigidly. The body creates fibrotic scar tissue. The NICE's guidelines specifically document severe adverse events where patients developed crescent-shaped fibrous bands across the mid-vagina following these laser treatments.
The physiological result of generating rigid scar tissue inside a dynamic expanding canal just sounds like a recipe for intense chronic pain.
It is. It creates partial vaginal obstructions. Women who sought out these lasers to fix a mild loss of friction ended up with severe dyspareunia, which is debilitating, searing pain during intercourse.
Oh, that's terrible.
And the scarring and altered tissue mechanics trigger intense muscle spasms. The documented interventions for these adverse effects are extensive. Patients require heavy pelvic floor physical therapy and, in some cases, vaginal Valium suppositories just to calm the neurological pain signals and muscle guarding caused by the laser scarring.
The severity of those outcomes perfectly illustrates why the FDA issued strict safety communications warning against the use of energy-based devices for cosmetic vaginal rejuvenation. It's also why medical regulators in countries like Australia have moved to entirely cancel the approvals for these specific devices. You go in trying to treat a sensory symptom of laxity and risk walking out with permanent fibrotic damage.
This is exactly why accurately diagnosing the root cause of the laxity is the paramount step in any treatment plan. A thermal injury cannot reattach a torn levator muscle,
No.
nor can it replace the systemic hormones required for tissue health. If a patient is dealing with estrogen deprivation, which is clinically termed genitourinary syndrome of menopause when it occurs later in life, the medically validated treatment is localized vaginal estrogen therapy.
Right, which is so simple.
It is. Using an estrogen ring or a topical cream directly replenishes the receptors, restoring the mucosal thickness, the elasticity, and the natural lubrication without introducing any structural trauma.
And if the diagnosis points back to the actual birth trauma, like if a doctor confirms a levator avulsion and a weakened PC muscle, what is the safest, most effective intervention for that structural deficit?
The clinical gold standard is pelvic floor muscle training, or PFMT, and that has to be conducted under the strict guidance of a specialized pelvic floor physiotherapist.
So not just regular Kegels.
No, this is vastly different from generic Kegel exercises.
Yeah.
Because the pubicocugus is detached, a specialist must map the pelvic basin, identify which surrounding muscles are actually intact, and design a targeted rehabilitation program.
Oh, I see.
Through neuroplasticity and strength training, the patient learns to recruit and hypertrophy the surrounding intact muscles to compensate for the avulsion. By rebuilding the overall core stability and muscular tension in the pelvic sling, patients can significantly improve the strength of their orgasmic contractions and regain mechanical function.
Bringing this deep dive full circle for you, the listener, we set out to determine if birth trauma can affect orgasm intensity through vaginal laxity, and the clinical reality is a resounding yes.
Yes, it is.
A levator avulsion physically widens the pelvic opening and strips the mechanical tension required for intense, gripping orgasmic contractions. But the sensation of laxity is a complex intersection of structure and hormones. A profound loss of friction is just as likely to be caused by a silent crash in estrogen levels drying out the tissue as it is by a muscular tear.
Exactly.
Understanding that difference is the key to avoiding risky, unproven interventions and finding therapies that actually restore your physiology.
You know, I'd leave you with this final thought. If the pelvic floor is a highly sophisticated muscular hammock, one that is absolutely essential for spinal stability, for securing the bladder and rectum, and for the fundamental mechanics of sexual pleasure, we must critically examine how the medical community treats it.
Definitely.
If an athlete tears a ligament in their knee, months of targeted physical therapy and precise rehabilitation are considered a mandatory, standard part of their healthcare journey.
Without question.
Yet when a woman tears a muscle entirely off her pubic bone while bringing a human being into the world, the rehabilitation of that trauma is still widely treated as an optional, almost taboo luxury.
It's wild to think about.
It is. The standard of postpartum and aging healthcare demands a massive structural shift, something for you to explore and mull over.
Until next time.